Hello everyone, can you guys hear me? Can you
Yes,
guys
Dr.
hear me?
Afifa. Yes, Dr. Afifa, please go ahead.
So is my screen visible to you guys?
Yes, please.
Can you guys see my screen?
Yes, we can see your screen. Please enlarge it.
Is my screen visible?
Yes, it is.
So good evening everyone. Today the topic of my discussion is doing more with less. I am Afifa and I am basically working as a senior registrar in the Department of Neurosurgery at Calcutta National Hospital. And here today would be discussing the minimal access basically, and in the form of cranial neurosurgery basically primarily, and we would be discussing the advent of syringe port. So basically, syringe port is basically a cylindrical tubular port it to the neurosurgery armamentarium, and the rationale of using a syringe port is basically that we all know that the usage of tubular systems basically results in decreased and minimizing the damage to the adjacent surrounding tissues, because there is a thought that it results in equal pressure dissipation by the walls of the cylinder. So basically, we all know that this is going to result in minimal damage to the adjacent white matter tracts, and this is going to result in minimal tissue damage. Here we can appreciate that these are the most famous Y-core tubular retractors, which we know that they are basically single use because they're disposable, and they obviously necessity is the mother of invention. So the whole concept of using a syringe port is basically, we can see in this animated diagram, is that we can access, with the help of syringe port, we can access deep-seated lesions as well as surface lesions. So the length of the syringe port can be edited, and can be edited as per the direction and as per the target, the distance of the target from the surface. So in this particular animation, we can see that this is a tubular port that we can see, and it is targeting a deeper structure, which we can see here. So in our scenario, I would be basically discussing how we innovated the syringe port and how we use it in our setup, because we know that we have work in a resource limited country, so we have to tailor things according to our needs. So we devised our syringe port with the help of basic syringes, which are like 5 and 10 and 20 ml syringes. So we all know that the syringe port can be tailored as needed before the dural incision. The depth of the tumor from the level of the skin should be measured to the workstation to know the length that is required for the different syringes and for the different lesions. The port should be long enough in order to reach to the deepest portion of the tumor along the planned trajectory, because if the tube port is going to be short, so then this is going to cause difficulty with the angulation. So a shorter port will result in hampering the angulation, and it's going to result in obviously hamper the access to the margins of the tumor as well after the initial decompression has taken place. And the width of the port is also going to vary depending upon the nature of the lesion and its vascularity. So this is how we basically create the syringe port, that we're going to, depending upon the length of the target that we have, and depending upon the length of the axis that we want, we cut the syringes, and we obviously smoothen out these sharp edges. Then the front end and the back end, both of them are actually cut and they're smoothed out. Then for deep-seated syringes, what we can do is, with the front end of the metallic trocar can also be made conical in order to facilitate the separation of the white matter in a dissipated manner. And this is again one of the innovation that has been done by our friends in India, that they have made it for their regular usage. This is a metallic trocar which is conical in shape at the distal end, and they have this stereotactic system attached to the one proximal end, and this is the syringe or the tubular retractor shape that we can appreciate here. So we know that the neuronavigation tool adapters can be attached to the rear end of the trocar or the syringe flange, and or directly to the posterior end of the syringe when we are using a 10 ml syringe. So when do we use these syringe ports? The syringe ports can be used basically for multitude of lesions. You can access basically, we very commonly use them for the hematoma surgery. So it's a very frequent surgery that we perform, which is endoscopic clot evacuation. So depending upon how far seated the clots are and the various locations, we've even performed posterior fossa clot evacuations with the help of similar syringe ports. And we can also use it in the intraventricular lesions as well as deep-seated gliomas. So this is the rationale and this is the thought process behind the usage, that what we do is nowadays, I'm going to share this technique further on in the further slides as well. So this is a Foley catheter that we can see here. So what we do is that we're going to pass via the syringe, we're going to pass the Foley catheter, dilate it in the distal end, and that is going to cause basically harmless dissection of the brain parenchyma. So because Foley catheter at the tip is rubber, so we know that it doesn't have any sharp edges. So we know this is going to cause dissection for us. And then once that tract is created, we advance the syringe further on, and then we can insert our instruments through it. So this is what has been depicted in this particular diagram. This is the technique. So this is how we do it. Here you can see that I have a syringe in my hand and we've advanced the Foley catheter. I'm going to inflate the balloon of the Foleys. That can be appreciated. Once it's done, then when we're going to put it inside, after measuring that if it is in accordance with the size of the burr and then you proceed on further. So we'll be discussing few cases that we did with the help of syringe port. So this was a 23-year-old female who presented to us with the complaints of headache. So she had a large intraventricular lesion, which was primarily in the right lateral ventricle, which was had a slight contrast enhancement, likely looked like a subependymoma because of its attachment to the septum pellucidum, which we can appreciate on the coronal as well as the axial images. This is the peroperative navigation diagram. That is how we planned our trajectory. That is slightly lateral from the slightly anterior to the coronal suture and lateral to the midline. And this was our trajectory. This was the pathway that showed that this is how we're going to enter. So that's a pre-op image. That's the surgical video that I would like to share with you guys. So here we are advancing the scope. This looked like a soft, suckable, whitish colored tumor tissue. We looked at its boundaries. Once it was coagulated, then it was debulked with the help of Kuza. This we're dissecting around it. The biopsy was being taken down.
If we move it forward, Afifa, time is running out.
All right. So we removed it with the help of the ultrasonic aspirator. And this was our post-op picture. This was the clear surgical bed that you could see. And this is the per-operative started imaging when we went on. Then secondly, we also performed a similar case, which was an 8-year-old which presented to us with left-sided weakness. We again did it with the syringe port. So this turned out to be a high-grade lesion. Then another one, we performed another one, which was a 55-year-old who presented to us again with left-sided weakness. So there was a deep-seated lesion you can appreciate in the periventricular area. So this was also done near total dissection was achieved. This came out to be GBM grade 4. And this was another one, which was in the subfalcine area. Again, it was a high-grade tumor. And this image-guided MR was basically, this is a stereotactic navigation picture from our system directly. So this was basically done on a T2 weighted image because we knew that the lesion is contrast enhancing. So these were a few cases that we performed.